All right, we good? You can see me? Or do not see me, I guess? All right, good. All right. Moving on. Immunology. Let's cover the immune system real fast. So, in case no one knew, or has never had a mother who's decided to palpate the lymph nodes in your throat, your lymph nodes, as well as a number of other items in your body, construct part of your immune system. A lot of your immune system is a lot of filters, right? Kind of think of it like a Brita filter, right? You put water in, it goes through the filter, and all the nonsense gets stuck in the filter. So things like your lymph nodes, okay? Your lymph system works in a really cool manner in so much as basically plasma gets pushed out of your capillary bed into the lymph system, which kind of runs right next to it. And as it runs through the lymph system, things get filtered out, and then it gets kind of pulled back into your capillary system, okay? So if you are sick, right, the white blood cells will kind of propagate in the lymph node region that is affected, and it kind of just goes there. It's easier for it to kind of herd the germs into that one location and then have a response rather than have to go chasing it around. People who, like, it is possible to end up having to have your spleen removed, right? Your spleen is a giant squishy bag of blood cells, okay? Your spleen can hold, I think it's like 10% of your body's red blood cells or something like that. It can hold a significant amount of red blood cells. So in the event that you are going into shock, your spleen will actually like release the hounds. It will release the red blood cells and try to help you kind of compensate for shock. So patients who have had their spleen removed not only will have kind of some immune system compromise because they're losing this big old filter, but in the response to shock, like a hypovolemic hemorrhagic state, they won't be able to compensate quite as well. Your tonsils and your adenoids are in that throat area. That's what your mom palpates when she does like the whole, are you sick? You not feel well? And like does the squishy under the chin kind of check. And then you have the thymus. The thymus is right underneath your sternum and is a significant is much more significant when you're younger. Okay, it's much larger. As you get older, it starts to shrink because your immune system starts to kind of bolster itself on its own. It doesn't require as much enthusiasm. The thymus is where T cells originate from. Okay, hence T cells, thymus cells. Okay, but yeah, it starts to shrink as you get younger or get older. Is very active in younger children, and is just kind of a cool little squishy bit of immune system item right underneath your sternum. So you have different lymphocytes, right? Different white blood cells, lympho being white, cytes being cells, that float around your body and keep you healthy. And this is to kind of contextualize B cells a little bit. We also call them immunoglobulins. It just gets very nasally, that word. To contextualize a little bit, right? This is when you go to get your COVID antibody testing. They're checking for essentially your IgG and your IgA, or IgM, sorry, not IgA, IgG and IgM. So your IgG is like the immediate response. There is some sort of infection. Your body's like, whoa, bro, this isn't new. This is new. Let's go take care of it, okay? And then after your body, like the first week or so, your body's like, all right, cool. We've recognized this. We've marked it. Then it starts to produce IgM, or if you want to think of it as memory immunoglobulins, okay? They're like the secondary stage. IgA, IgD, and IgE have other functions. IgA is really inside of your gut, whereas IgE is sort of the immune response in an allergy. So it hangs out with histamine and all of those things to create that inflammation, that drippy nose, and all the other things you kind of associate with an allergy. Then you also have T cells. By far, killer T cells are like my favorite. They pretty much just go around and ninja other, like, invading bacteria and viruses, which just makes them really kind of cool. So you have your killer T cells, you have your helper T cells, which kind of hang out with the antibodies. So they kind of poke the B cells to produce antibodies. And then you have the suppressor T cells, which keep the immune response from getting out of control. Okay? Because everything in your body has like a control, like, a starting point and like an ending point, right? So that ending point keeps everything from getting going too much, right? This is like the suppressor T cells aren't able to suppress your immune response in an anaphylactic response as enthusiastically as a person who does not have anaphylaxis. Kind of like sort of that concept. Your body is really cool in so much as it creates what it needs, right? So if you are not sick, you don't have a lot of white blood cells floating around. You might have a few here and there, but what you really have kind of floating around are the hemocytoblasts, or the stem cells, right? And those will differentiate based on what the body needs, right? So if you need red blood cells, it'll go down. Hold on, let me get some come on. Get some drawing skills going on here. So if you need red blood cells, right, it'll go down this pathway. If you need, I missed the eraser. If you needed thrombocytes, right, the thrombocytes are the same pathway going down in this direction. But if you needed plasma cells, which are also a type of B cells, you'd go down this way, right? So a number of different factors will kind of help your body determine what it needs and then create the appropriate cell response. If you have some level of like blood work laying around in the house that you're like, let me look at this, you will see that you do have white blood cells, like a normal count for white blood cells, and they will measure basophils, neutrophils, eosinophils, and monocytes. And different proportions of these white blood cells tell doctors what's going on. So if you happen to have I think it's a high level of eosinophils, that usually means it's a viral infection, as opposed to if you have like neutrophils or basophils, which might be more that it's bacteria. Okay, just kind of a cool little thing to know. You could look at that later at your own leisure if you're kind of interested. Again, brief overview. We're not going to go crazy into this. We're going to just focus on what's important. So once your body has been exposed to some level of an antigen, your body posts a response, right? And in thinking back to like this whole COVID thing and how we're trying to make vaccines, this is the idea that you're presenting an antigen to the body in a small amount where it will be like, that's not new, or that's new, that's not something we want in the body. Let's create some level of protection against it, right? So what it does is it creates memory cells and antibodies. So the memory cells will kind of hang out in like the areas where it's most commonly that either an antigen will enter your body, like your GI tract, or the lymph nodes and the spleen where it will be filtered out pretty quickly. Others kind of wander about the body and do a patrol, sort of like, cops on foot patrol, right? They kind of wander around, they make sure that nothing funky's going on, and go from there. And then if you are exposed to this antigen again, your immune system can not only destroy it, but can destroy it a lot faster than the first time it recognizes it. Because the first time it recognizes it, it needs to kind of figure out what's, how to get rid of it, right? Are you a virus? Are you bacteria? What do I need to do to get rid of you? One thing that you do kind of have to have a very clear understanding of is the difference between natural immunity and acquired immunity. Natural immunity is like the stuff you're born with. You don't really require a previous exposure. most of the time it's passed on through placenta, through the placenta or through breast milk. Okay, so this is part of the reason why kids, like really little babies who breastfeed, don't get sick, because they're taking mom's immune system into their body through breast milk or through sharing blood, right, when they're in the womb. So they're kind of protected, right, because everything that mom was exposed to, probably about 98% of that baby is protected from. So as you start to wean children off of breast milk and move them to solid foods, they might start to get sick a little more frequently, because they're losing that exposure if they have not been exposed to it themselves, right? So this is why we start that vaccination process while they're still very little, because they're kind of sharing, right? So passive would be you're getting it through mom's stuff, and then you have acquired where you're vaccinating, right? So we're giving you a small exposure to a specific antigen. Your body is able to develop memory cells, and it will last long term. However, in vaccination, sometimes the body doesn't seroconvert, which means it doesn't actually create antibodies. So this is why some people who've gotten, for example, the hepatitis B vaccine won't necessarily have an immunity, okay? Because sometimes that's one of the vaccines that doesn't always necessarily convert to your own immunity, okay? You might have it for a short period of time, but like this, and this is what they're dealing with at the COVID issue right now, is like, oh, it's not a long-term immunity. We don't know if, those antibodies kind of go away, or if it does create those memory antibodies. Because if it doesn't create those long-term antibodies, you're going to have to end up getting a shot like every year, sort of like the flu vaccine. Specifically in regards to the flu vaccine, the flu virus mutates very quickly and very easily, which is why every year you have to get a new flu vaccine, is because that virus looks a little different, so your body doesn't recognize it. Okay, there's also different strains of the virus that happen to pop up that are more popular than others. It's like, when we had swine flu, we have H1N1, you have flu A, flu B, right? These are the ones that seem to pop up a lot, but they might mutate, so your vaccine only gives you a certain level of protection. The vaccine does give you a little added boost, though, in preventing the flu from getting extra bad. So you'll have a little bit of a jump on your immune response with the vaccine. In regards to your other passive immunity, you can get artificial passive immunity through, they were doing this with COVID as well, when they were doing the transfusions of plasma. They were giving you other people's antibodies, okay, through blood transfusions. So just kind of a brief idea of the different ways that you can get types of immunity. I do happen to see the natural immunity, passive natural immunity. I just kind of know the difference, because the maternal antibodies one does pop up on tests every once in a while. So sort of like how the heart has like its own like cool characteristics of, automaticity and all that other stuff, your immune system also has pretty unique characteristics. So first of all, most of the time, like 95% of the time, it's able to distinguish self from non-self, right? So if there's some sort of foreign invader, it knows that it's not good and it can attack. The problem with that is sometimes, especially in the case of autoimmune diseases, that's a problem, because your body can no longer distinguish self and non-self, and it starts to attack itself. And this is troublesome, because then you have to suppress the entire immune system in order to keep it from attacking the body, and then you just end up with being sick a lot, because it becomes opportunistic for other external factors to create issues. There's also an issue in transplants, right? Patients who have a heart transplant, lung transplant, etc., they need to take immunosuppressants for the rest of their life in order to keep their immune system from attacking their new the new foreign organ that they've received. For some reason, it doesn't really affect patients who receive valves, heart valves. So if they use porcine or bovine heart valves, for some reason, it doesn't have the same immune response that the body pitches when it's like a human organ. I think it's just zoologically different. So the body's like, I don't know what that is. I'm just going to pretend it's not there, and just carries on about its day. One of the other characteristics that's really important for the immune response is the memory cells, right? So it creates the sort of Rolodex of things that it recognizes, because then instead of you getting really, really sick, it's like, nope, we got this, and it can shut down the common cold maybe after 2 days of the sniffles, rather than having to be, a week with the sniffles and a fever. It does create antigens or antigen-specific antibodies in response to new exposures, right? So those new foreign invaders get their own antibody that allows the body to use those memory cells in order to launch a rapid response. And we talked about this a little bit before as well, that it's self-regulated, again, like about 95% of the time. When a pathogen invades, that's when you get an influx of white blood cells and other immune cells, whereas, people who have immune diseases might have a high level of white blood cells or, other immune components more than they should. The important thing to understand for immunology is allergic reactions, okay? Allergic reactions and anaphylaxis. This is where we shine in pre-hospital care, right? Because we can do something about it. If somebody calls and it's like, I don't feel good, I got the vaccine a couple days ago and now I have a fever, okay, I'm not surprised. That's a normal reaction. But if you have somebody who's, got stung by a bee and now they are, swelling up and their airways closing, this is where we can kind of fix things. So an allergic response usually starts by an antigen entering the body, and it can enter in a number of different ways. And this is always a test question. How can a antigen enter the body? So almost any other way that you can think of, right? Injection, ingestion, inhalation, and absorption. The number one way that an antigen traditionally enters the body is through ingestion or injection. Okay, injection being you've received a shot, you received a bee sting, a bite of some sort, and ingestion is like, okay, foods, right? Peanuts are a big trigger issue for kids these days. Your body recognizes this as something that's going to cause it an issue. Okay, it might be even hypersensitive to it, which is, what the reaction, we call it hypersensitivity reaction. And it, rather than just kind of being like, okay, cool, let me just give you a couple white blood cells, couple T cells, couple B cells, and we'll respond to it, it goes overboard, right? So it creates a full physiological response rather than just kind of maybe some sneezing or something. Usually, and this is like about 98% of the time, you have to have been exposed to the antigen previously in order to develop an allergic reaction. I say usually because every once in a while you do have a person who has what we call an idiosyncratic response, where it's the first time they've been exposed to something and they immediately have a reaction. And that's either because they don't realize they've been exposed to it previously, or their body is just that good, right? It's doing a really good job of kind of trying to protect itself. The two parts of the immune system that are the most enthusiastic during an allergic reaction are the mast cells and the basophils. The mast cells are I like to kind of call them the confetti of the immune system. So they're these large cells, and inside they are what we call granular. And when they come into they start to respond to an allergic reaction, they explode and they spray histamine kind of all over the place, right? if you've ever seen an allergy commercial, right? Histamine, oh, we need a histamine blocker, right? Histamine is what causes that the runny nose and the teary eyes and all of that jazz that we very closely associate with an allergic reaction. So basically what histamine does is it creates a leakiness inside the blood vessels and the capillary beds primarily, right? So it allows the plasma to kind of ooze out to kind of it's essentially trying to push the antigen out of the system. The secondary response is heparin, right? Your body actually does naturally make heparin, which is kind of cool. Sidebar, your body also naturally makes its own narcotics, which is why we have morphine receptors in our brain that makes people get high, because your body actually does have a way to create its own narcotics and kind of dull pain. So people with really high pain responses may have more of their own ability to create its own natural narcotics. So then heparin comes and it thins the blood out because, again, it's trying to reduce the impact of the allergen. It's trying to segregate it out of the bloodstream or the GI tract or wherever that antigen happened to have entered your body. Here's your mast cell and your basophil. I just enjoy the mast cell. It just looks so fun. It just participates a lot at allergic reaction parties. So there's different types of hypersensitivity reactions. Again, we like to classify things from type 1 to type 4. Type 1 are your immediate reactions. Type 2 are tissue specific. So like, for example, say you are allergic to a certain detergent, right? And you put on clothing that you washed in that detergent, you might end up with like a rash, right? And then you have immune complex mediated reactions and then delayed reactions, okay? Your localized allergic reactions, we just said, if you come into contact with the allergen, you start to release all of the chemical reactors, right? The histamine and the heparin associated with an allergic reaction. So this is like, I'm allergic to cats. I come into contact with a cat. I start getting itchy eyes, a runny nose. I might, I'm really allergic, really severely allergic, I might end up with angioedema, right? Which is the airway, swelling in the airway. Urticaria, where you have those hives, right? And pruritus, like that rash, the heparin can cause pruritus, which is like a little bit of like a bruising, like a bruisey looking rash. Allergic reactions are one thing, and we can treat those. Usually we just kind of hit them with some Benadryl, maybe a Solumedrol, right? Because the steroid is really good at stabilizing those cells, those mast cells and stuff, from exploding and creating issues. But anaphylaxis, hold on, is life-threatening. Okay? People die from anaphylaxis every year. I went to college with a guy who he was allergic to everything except for pork, greens, and potatoes. He was severely anaphylactic, and he ended up going to the ER at least 3 or 4 times during his college career that I knew him, and he was a year ahead of me. And he actually ended up ultimately dying from anaphylaxis, which was just crazy to hear. It's very serious. This is where you want to, be very aggressive and treat your patient, right? Things like epinephrine and Benadryl, together with Solumedrol and an albuterol treatment, right? This anaphylaxis is probably the only life-threatening issue that we can 100% deal with in the field, where you get to the hospital and they go, all right, cool, put them over there because you did everything already, right? You can't do that with a cardiac patient because maybe they need, a stent. Stroke patients, right? Maybe they need to get TPA. A fractured bone, right? They need a cast. Anaphylaxis, 100%. You can treat start to finish the entire protocol that the hospital would end up doing anyway. So it's why it's important for you to understand what you're looking at and how to treat it. So it affects the body in different ways, right? So cardiac issues, you're definitely going to have a patient who's probably going to present with tachycardia. The histamine, because it creates this leakiness of the capillary beds, will promote hypotension, right? That's why a patient can go from being anaphylactic to being an anaphylactic shock, right? Because it starts to redirect the fluid, the plasma, out of the vasculature and into a less functional location, right? That's also why you get this patient who has that swelling, right? So those two kind of go together. When they have that angioedema, they might just look really puffy. That's all that fluid that's being redirected outside of the vasculature. Very commonly with anaphylaxis, especially if it's an ingestion, you'll have a patient who has nausea, vomiting, and diarrhea, okay? If they are aware of what they're allergic to, like, oh, I got it. Sorry, I just killed a mosquito. If they know that they've eaten something, like they'll probably know, right? It's your body's trying to get rid of the antigens. So vomiting and diarrhea makes sense, right? But again, think about it. You could still lose a potentially large amount of fluid volume through vomiting and diarrhea. Cutaneous, we talked about that already a little bit, right? You have your angioedema, you have hives, the patient might appear flushed, right? Again, that's a side product of the histamines and the heparin redistributing the blood, the plasma, as well as some of the red blood cells. And then respiratory, right? The airway edema. The patient might have bronchial constriction because your body is essentially trying to hunker down the fortress to keep more antigens out and push the existing antigen out of the body. So bronchospasms are very common, as are wheezing. When the airway starts to swell up with the edema, you're going to get some stridor. Very kind of textbook presentations, but you can have some level of variation, which is kind of interesting as well to see. I always use this picture because it's probably one of the most accurate depictors of what anaphylaxis and angioedema look like. You have a patient whose eyes are swollen shut, right? Within the first hour is like usually when people die, okay? There's plenty of people who have anaphylactic level reactions to things who don't carry their EpiPen. So I don't know. I don't know if it's irresponsibility or they don't believe it, but sometimes people just don't carry it, so you have to act fast. But you also need to be able to recognize it and recognize that it's progressing, right? So it might start with just like an itchy throat, maybe a little trouble breathing, a runny nose, itchiness, right? And then it might progress to be worse and worse until you're, trying to tube a patient who has no airway left. So could always be an issue. Some of the most deadly anaphylaxis causing sources of antigens are bees. Okay, that's usually bees and ants. That's usually a test question. Fun fact: epinephrine auto injectors actually have a backup dose of epinephrine. So if they've given themselves one and you're having one of those days where you can't seem to find your epi on the ambulance, you could try to give them their second dose that's in the EpiPen. And again, it depends on manufacturer. There's a lot of people who are allergic to nuts and they don't necessarily check their ingredients very well. So that might be, if they may have eaten that medications. Sometimes with medications too, you might have a patient who has taken a medication for the first time and starts to have an allergic reaction. Okay, that's one of those idiosyncratic things. And this is why it's important for you to do a very good patient history to find out what they've been exposed to if they don't know, right? Common things, okay, well, were you outside? Were you stung by a bee? Did you feel a bite? Do you have any lumps on your body that, or bug bites that you didn't know before. Are you, foods? Did you change any food? Did you go to a new restaurant? Did you change detergents? Is there anything else in the environment that you've changed recently? Any new medications? There's a lot of different things that people can be exposed to that, you really should do a thorough evaluation of your patient to find out what's going on, because it will help in the long term in terms of not only the patient avoiding those things, but you being able to treat it. For example, if you have like a patient who was stung by a bee or has eaten their antigen, fluids, right? IV fluids might help flush that out of the system a little faster. If you have somebody who's been topically exposed, cleaning the location where they've been exposed can help reduce the level of response that their body is pitching, that, to reduce the level and the extent and the time of that the anaphylactic reaction is going to occur. So the first thing is that when you are exposed, your body does produce IgE antibodies. Then they'll hang out. Those antibodies remain on basophils. So when the antigen is reintroduced, those basophils respond, and those are the ones that start to release the basophils and the mast cells, right? Because they kind of hang out together. And those are the ones that will release the histamine and the heparin and all the other chemical mediators that promote the anaphylactic reaction. In addition to histamine, there's leukotrienes. I think these, and kinines, those two. Those were the ones that were killing people during the flu 2 years ago, okay? It was creating like a leukotriene and kinine storm, and was just creating a level of vasodilation and and secondary to that, the hypovolemia that was uncontrollable, and people were dying from that response. Eosinophils will also create a chemotactic factor, right? So it's basically your body's doing everything in its power to create an inflammation level to reduce how far the antigen can spread, and then a very permeable state so that not only can it reduce the spread, but it's pushing it out of the main systemic circulation. So that's your 1-2 punch of anaphylaxis. Histamine is considered to be a protein. It promotes your vascular permeability. It is a rapid onset, but a very short lifespan. And then I think we talked about all the other things, right? It causes contraction of smooth muscle. There are there's 2 to 3 types of histamine, right? So you have H1, which is in your GI tract, and H2, which floats around the bloodstream. And there's H3, which I'm not sure where that lives, but it does other things as well. So it causes, that high level of permeability so that you lose volume, and creates contractions of the smooth muscles as well. Histamine's pretty... Oh no, there's 4. Look at that. I forgot all about that 4th one. Histamine does a lot of different things, right? So in anaphylaxis, we're really kind of primarily concerned with the... Hold on, let me get some pen. You're really kind of concerned over here. Go away. With the central nervous system, cardiopulmonary system, the skin, and the respiratory tract, right? But that goes over there. You may see some GI issues as well, okay? So that neurotransmitter release in the central nervous system, right? So you're going to elevate your heart rate, elevate your respiratory rate, vasodilation, right? So you start to become hypovolemic. Heart rate goes up. You have the skin that's I'm not even going to try to say this word right now. I'm not doing it. Endothelial permeability, right? So you end up with hives. You'll end up with nausea. You'll end up with increased mucus from the respiratory tract because of the increased permeability, right? Here's some mucus too. You also have the smooth muscle constriction, right, with the respiratory tract, so you'll have increased wheezing. Okay? A lot of different things that histamine does in the body that, you need to kind of be aware of when looking at a patient who's potentially in anaphylaxis. Too far. Leukotrienes are like the precursor for prostaglandins. Prostaglandins being what help create inflammatory responses. They're slow and long-acting, okay? These are the ones who primarily cause respiratory effects. So if you ever hear, I think it's Advair, is a anti-leukotriene, right, for patients who have asthma and COPD, right? So it reduces the bronchoconstriction from the leukotrienes by reducing the amount of leukotrienes that are able to be put into the bloodstream. Also increases the vascular permeability, so you have like layers of permeability while this patient is experiencing increasing levels of hypovolemia. So this is why fluid is especially important in anaphylaxis. Excuse me. If you look at the anaphylaxis protocol, I think you can give the patient up to 2 liters of fluid. I think one's on standing order and one's on medical control, right? You actually might be able to do 2 standing order. I'll have to check on that one. Right, so that's a lot of fluid, right? Because they're losing a lot of fluid. Eosinophil chemotactic factors, right? This is histamine, leukotriene, helps promote more of those release, more inflammation in the body. And there's a lot of other things, right? So this is like a multifactorial issue in the body, but we can respond appropriately. There are some things that can kind of mimic a anaphylactic reaction, but it's also very common to see very similar treatments, right? Especially severe asthma. Had a call once a patient came over as a 14-year-old not breathing. So we got there and this kid is red and flushed, laying on the floor, breathing poorly, history of asthma. He had woken up from a nap and complained of difficulty breathing before collapsing. Okay. Initial thought, hit him with epinephrine, right? Because if it's an asthma attack and he's gone into silent chest, then we need to move quickly. So we hit him with the epinephrine and he takes a big deep breath and sits up. And we're like, okay, cool. He's got wheezing bilateral now. So we treated him with albuterol and ipratropium, going with the idea that it was an asthma attack. So we ended up giving him magnesium and Solumedrol, and we took him to the hospital. As we're about to leave, though, we're like, oh, does he have any allergies? And the family goes, yeah, he's allergic to fish. Now, a lot of y'all don't know me that well, not through your own faults, but I can't smell. I sheathed cranial nerve 1 about 10 years ago and have not been able to smell since. So I didn't know that the entire house smelled of fish. The family had been cooking dinner downstairs, and the smell of fish actually caused this kid to go into an anaphylactic reaction, which is insane. Right? You think like something so simple as the smell of fish made him go into an anaphylactic reaction. So we gave him fluids and kind of went over like, okay, well, what was the appropriate treatment? And it was pretty much exactly the same as what we had treated him with for asthma. The only thing being we had given him MAG, which is in the asthma protocol and not the anaphylactic protocol. Okay, because in the city, pediatrics are not treated with Benadryl, or at the time, pediatrics were not treated with Benadryl for anaphylaxis. So, and we gave him ipratropium, which is in the asthma protocol, not the anaphylactic protocol. So, grand scheme of things, he got the appropriate treatment, but it wasn't the appropriate diagnosis. So, again, you have to kind of be careful and make sure you get a good history, but there's also going to be times when you need to act, right? If you have somebody who's not breathing, you have to make sure that you do something. And that kind of works as you start doing your rotations and stuff. And I'm sure you have all recognized this as well in your own careers as BLS. You start to get that intuition, right? You start to have that knee-jerk reaction of, I need to do this. And those intuitions, once you start to develop a strong pattern or recognition, aren't necessarily wrong. Sure. Honestly, I'd probably say epinephrine, because you can do BLS procedures for the airway. And again, this is also going to depend on if you have anyone with you. Yeah. Potentially, yeah. Like, if that's one of those chicken or the egg situations, right? Like, and also you have to kind of take into consideration, like, one, do you have an auto injector, or are you drawing up the medication? Two, how long has the patient been down? Like, if they've been down and not breathing for 10 minutes, that epinephrine's not going to do as much good as quickly as you would want it to. So you're going to need to get some oxygen into that patient. Are you going to hit them IV or IM? Okay. Are you able to get an IV? Because you might have to actually, you might call and say, hey, I have this patient who's in severe anaphylaxis. Their airway is completely closed. I want to give them, 0.3 milligrams of 1 to 10,000 epinephrine IV rather than 0.3 milligrams IM. Right? If they're so significantly hypotensive that they're shunting blood to their core and you have no blood flow to that to the musculature, that IM medication isn't going to work. So, and the funny thing is, all of these thoughts will happen so quickly in your head after a while that you'll just, again, your that intuition be able to make that knee-jerk reaction really quick. You're welcome. So I think we talked about all of these effects, these various effects that you might see with anaphylaxis. If you have any questions, feel free to throw them out there. And here we go. Airway, right? So for the most part, airway death in anaphylaxis is usually related to airway obstruction. You can ask the patient things like, does it feel like it's hard to swallow? Does it feel itchy in your throat? Is this how your voice normally sounds? Right? Those are some good questions. You might see cyanosis around the airway, like around central cyanosis of the lips. Patient might have various levels of breathing issues, from anywhere from dyspnea to wheezing to no breath sounds at all. And that's all going to kind of determine how quickly you manage the patient and whether or not your quote-unquote, as I like to call it, my concerned face comes out, right? Am I going to be really serious, or am I going to be able to like chit-chat with the patient a little bit? It's important to determine if the patient has or has not administered an EpiPen. If they have administered an EpiPen and they say that they're starting to feel a little bit better, you have a little bit of time to maybe get an IV, get them some fluid, do some Benadryl, and then, see if they're going to need another round of Epi. If they haven't, this is also one of those things where you're going to have to probably give the Epi a lot faster or a lot sooner than if you were just kind of chilling with a patient who is able to talk to you with no problems. There is a very strong correlation between allergies and anaphylactic level allergies and asthma. Okay? So not only are you dealing with somebody who may have, an anaphylactic reaction, they also might be complicated by asthma as a comorbidity, right? So you might have to increase the level of speed with which you're working on a patient who does have that comorbidity. Beta blocker usage also because it dulls the body's response to epinephrine, right? So if epinephrine is being administered and you have a patient who's on a beta blocker, that might not work, or it might not work as potently as you would expect. So just, again, something else to keep in mind. Rapid or regular vital sign assessment is important for any critical patient, especially for those anaphylactic patients. Again, remember, you're going to be giving this patient a significant amount of fluid as well as epinephrine, right? Epinephrine, one of the side effects is that patient feels very jittery afterwards. So you might have fixed their anaphylaxis, but they feel kind of crappy because now they're like kind of like doing like the shake, like they have like serious chills kind of shaking. But you also want to make sure you're listening to lung sounds well, because just because you can give a patient 2 liters of fluid doesn't mean that the 2 liters of fluid isn't going to end up right in their lungs, and now you have to give them CPAP on top of the epi and the Benadryl and the Solu-Medrol and the albuterol that you were giving them, okay? So this is why regular reassessment is essential. These are the standing, or max is 3 liters, sorry. I think it's 2 is standing and 1 is on standby with medical control. Again, this also may have changed. I know we're moving to the collaborative protocols, so when we do that, you're going to have to, you're using the collaborative protocols right now, so this might actually just need to be updated. If you do have a patient who isn't getting any better, right, they're seriously hypovolemic, you might end up giving them a pressor in order to keep their blood pressure in a safe range. All right, we're going to throw through collagen vascular disease. Collagen makes up tissues. If anyone has ever seen a commercial on TV for moisturizer, just like anything else, your immune system is traditionally what decides it's going to go and attack collagen, or you have just a collagen issue to begin with. Lupus, okay? Of all of the things in the textbook, lupus is probably the more important one for you to kind of be a little bit familiar with. You may end up dealing with a patient who is having a lupus flare-up, okay? A lot of them are on immunosuppressants to keep the body from attacking the healthy tissues, right? So they might end up with chest pain, heart problems, lung issues, like really bad pneumonia all the time. They might have some sort of level of kidney issues, or they might be anemic on the regular. Traditionally, the lupus, systemic lupus, gives the patients a quote-unquote butterfly rash across their nose and underneath both of their cheeks. So you might have a patient who's like, hey, yeah, I have lupus. Unfortunately, women are the ones who traditionally get lupus because autoimmune diseases seem to be, giant lesbians. They love women. There's your butterfly rash that you'll see a lot of times the patients will be dealing with. Scleroderma. Basically, what happens with scleroderma is it causes your immune system to increase fibroblasts and create extra collagen in the body, which causes things like muscle and joint pain due to stiffness. The skin might be very hard. It's not a great disease. It's like a slow building death, okay? Because your body essentially starts to turn itself into stone. You might have a difficult time getting an IV on a patient who has scleroderma. You're not really going to be doing much of anything for this patient other than managing symptoms and bringing them to the hospital. It's just like any other chronic disease that you will really be dealing with, okay? So you might have a patient who has local patches or linear patches of it. We're not going to worry about it too much. There's another image of scleroderma, right? It can cause thickening and hardening of the skin. It can cause Raynaud's, right, where you have like the reduced circulation to the fingertips. The problem with scleroderma is it doesn't care where in the body the collagen it's affecting. So you can have a patient who's got coronary artery disease secondary to scleroderma because their coronary arteries started to harden and then thicken and narrow. Again, diffuse looking, tight, weird looking skin. I don't know why we spend so much time on scleroderma in the textbook, honestly. Transplants, okay? Kidneys are the #1 transplanted organ in the world. There's a new name added to the national organ waiting list like every 10 minutes, okay? People can be a live donor for certain body parts, not the heart, obviously. Liver, kidney, those two are the ones where you can actually, share your spare. Liver does recreate itself, which is sometimes great for some people because if it's a close relative match, the body will have less likely be to reject it, okay? That's one of the biggest problems in transplants is that the two issues is one, that the body will reject the organ, or two, long-term immunosuppressive therapy, okay? So if you have a patient who has gotten a kidney transplant or a lung transplant or whatever and happens to, work in a healthcare setting or in, I don't know, an elementary school where all of these little slimy children have all these germs, right? They're going to, if they're on immunosuppressive therapy, they're going to get every single infection, right? Because they're just reducing how well your immune system works. Most of the time, right after transplantation, the patient might pick up a level of infection that was brought to you by the donor, right? They do a lot of screenings before they will, give a patient an organ that has some level of, issue associated with it, sort of, like the viral infections or anything like that. They'll try to really screen those really well. A lot of times if your patient has a transplant complication, when we talked about it's rejecting it. So a patient might experience fever, pain at the site, potential signs and symptoms of sepsis, depending on what organ is being rejected, is going to really dictate what your signs and symptoms are. Okay, so, patients who may have gotten a kidney transplant might be urinating blood, okay, for example. One of the things that I did happen to learn is if you have a patient who has had a heart transplant, who is in an SVT, you cannot give adenosine. When they hook the heart back up into the new person, adenosine no longer works because the vagal nerve stimulation is not connected. So a patient who is an SVT does require cardioversion. If you are transporting a patient who has had a heart transplant, you will most likely be talking to their transplant doctor who can give you a certain level of guidance in terms of what you should be doing, because they are going to know the patient best. In addition, if you have a patient who has had a heart transplant and it's relatively new and they're having chest pain, it is unlikely that they are having an MI, okay? That's a squeaky clean new heart. It's been approved. It's gotten the stamp of approval from a doctor that it's healthy. It's not common that will be a coronary artery disease related MI. Just throwing that out there. What else we got? Drug toxicity, right? There's a lot of, these are some of the drugs that you might see that are keeping the patient from rejecting. So this is one of those patient assessment. You have a patient who maybe is unresponsive and they're like, oh, this is what they take. And they're like, okay, Prograf, cyclosporin, and CellCept, okay, this patient probably has a transplant, right? So just keeping those things in mind as medications you might see as transplant medications to kind of guide your treatment of a patient. Cool. All right, cool. How's everybody? Gert. All right. Any questions? He's just comfy. It's okay. uh, someone's got to check on. Someone's got to check on Jonathan and Rob. There's Rob. Hi, Rob. Just making sure you didn't trip and fall and just leave the phone looking straight up at the ceiling. The others got it. Yes. Mm-hmm. No, luckily I have gotten to all of my anaphylactic patients prior to needing to intubate them. I will tell you a quick story about a young girl who lived right around the corner from Jamaica's ambulance bay who was allergic to a lot. Tree nuts, regular, like other nuts, because there's tree nuts and then there's like peanuts. Peanuts are like underground nuts. Tree nuts being walnut or pistachios and almonds and stuff like that. So we got the first call, and it comes over as like a baby in anaphylaxis, and she was all sorts of puffy, and she was crying, but you could hear the stridor. So we hit her with the epi right away. Crying, little kid. She's like maybe about a year old. Did really well, right? So she bounced right back because kids are super bouncy. Yo, you guys got snacks? So Raya. They're down the hall from me, and they're sharing snacks, and they're sharing with me. It's very rude. So we got the call about 3 months later, same address, same little girl. And I was like, oh, okay. So again, hit her with the epi right away. So she had an allergic reaction to, I think, peanuts. Grandma fed her some pistachio ice cream. She had an allergic reaction to that. Another 3 months later, we got her again. And I'm like, all right, this little girl is like my new best friend. Like, she's like, now I think she was like about two-ish now. And she had fish. They were cooking fish in the house again. And I was like, wow, again with the fish. Fish, for some reason, aerosolizes and just like gets all over stuff. And she had an allergic reaction. But by this time, her parents had her an EpiPen for her because they had an opportunity to go to the allergist. And they're like, yeah, she's allergic to, like, they just rattled off like a list of things that she's allergic to. I'm like, she's going to have a tough life in elementary school. But yeah, it was really cool to see, it is pretty impressive how quickly it does work. Had a woman once who her whole face was swollen and her eyes were swollen shut from an anaphylactic reaction from an antibiotic that she took for the first time. So, that she did not deflate quite as quickly as I thought she was going to, but it's pretty impressive how quickly the epinephrine really does work if you get there fast enough. I thought we were going to cowboy it. Yeah, I think medical control is a fair call. They might just have you give her Benadryl, the Benadryl and Solumedrol, because you can't necessarily monitor as closely as if she was in the hospital. So they might just, be more conservative, do this and this. Um, they might if they might change which epinephrine you give depending on. Not sure if the preservatives in Epi 1 to 1,000 are the same as the preservatives in Epi 1 to 10,000. So they might have you give that instead. Um, yeah, that's interesting. Yes. Yeah. 30 seconds to a minute. Yeah, it's a safe. And again, it depends on how bad the anaphylaxis is. Like, you might just be like, all right, cool. Like, I gave the epi and we're going to see what happens. And it just, the patient's to that point where, like, now you have to be more aggressive and do more things because you've only maybe opened their airway a little bit. So it really does depend on the patient and if the epi's going to, how quickly the epi's going to work. So, cool. Anytime. Any other questions before we do the last slides for today? Cool. All right. Let's do it. Let's do it. All right. I want to say of infectious and communicable diseases, probably the most important thing that we're going to take away from this is sepsis. Okay, sepsis can have a lot of different causes, but we'll talk about that in a little bit. So, in case everyone forgot what public health is from this most recent COVID extravaganza, an infectious disease is an illness caused by an organism. And communicability is how it's spread from one person to another. Some diseases, some infectious diseases are not communicable from human to human. Some diseases are not communicable from animal to human, which is zoologic. Right? So it really depends. Like tetanus, for example, right? It's an infectious disease. You usually get it from a puncture wound or some sort of, cut from like a rusty can or something else has been like hanging out in the environment a little too long. You cannot give tetanus to somebody else. It just doesn't happen, okay? But COVID, you can give that to other people, right? Cover your mouth, wash your hands. That's my TED Talk for the day. Infectious diseases can be geographically specific. Like, for example, you're not going to really find malaria in the United States, like in the Northeast United States. It's just not going to happen. But we will have West Nile, for example. Okay. Plague has been out and about lately. Thank you, 2020. China had a couple plague cases. Colorado had, I think, 1 or 2 plague cases, right? So things can happen. Ebola, right? Because now, if you think about it, our geographic locations have changed, but you also have to think about how it's transmitted, right? So West Nile, for example, not a communicable disease, but it's transmitted by mosquitoes. So if you are living in a location that is not mosquito habitat, like, I don't know, Siberia, you're not going to get West Nile. However, if you're in Siberia and you are meeting someone at the airport who just flew in from Panama and they happen to have a mosquito on them, you could still get a weird zebra type West Nile or yellow fever or something to that effect, okay? You have to try really hard. So, just keep that in mind. And this is also part of the reason right now that COVID's such a problem is because we don't have a quote-unquote effective treatment. And if you want to have a hydroxychloroquine debate at another time, sure, we can, but over it. Genetic factors also predispose people, to different infectious diseases, okay? And most of the time it's due to like pre-existing factors, okay, or little weird genetic mutations that make some people more prone to things than another. I don't know. Public health is a really interesting topic. It's really kind of vast, but that's your brief overview. So every agency needs to have an exposure plan, and I think we're kind of a little more finely in tune with that now that we've dealt with coronavirus, right? So if you think about it, our exposure plans are still kind of weak. Let's just call them weak, right? How many people are actually getting their temperatures taken before they come to work? How many patients are, how are we tracking exposures, right? If you transport a patient who has positive COVID, are we actually following up with you, or are we sending you for testing? These things are important, right? Are we actually disinfecting our ambulances appropriately? Are we using effective PPE, right? How many people are still wearing N95s on every single call? Right? So there's a lot of things in place that could be better as EMS providers overall, that we really could be doing just a lot better to protect ourselves. But at the same time, we kind of go out there with this like kind of air of, I'm good, I'm safe, I'm not worried, right? So anywho, you do have a level of personal responsibility, and I think that this this little infographic is interestingly a little more important now, because you're thinking about all the things that you could have touched, right? And how often do you really kind of touch something and not think about it, and then you touch your eyes, or scratch your nose, or any other number of things, right? We kind of are a little more in tune with these things now than we were previously. Eating and drinking in appropriate areas. And an ambulance really is just never an appropriate area, but we do what we can because we must. So wash your hands. There's a lot of different contact precautions that people can, really should be taking. And it depends on what it is, right? So we have the regular old contact precautions, and this is the charts that you usually see in front of hospital rooms before you go in and out, right? So droplet precautions versus droplet and contact, right? So if we're assuming that contact precautions would be like a patient who potentially has scabies, right? Where if you touch them, the parasite can then transfer to you. Airborne means that, it's in the air, you need an N95, which is flu, maybe COVID. We haven't confirmed that one. Droplet precautions is tuberculosis, right? So it has to be in a droplet to kind of keep it alive as it floats through the air, and the, mucosal membranes are really the higher risk there. Or, you could just show up in a big yellow hazmat suit and call it a day. Differences between sterilization and high-level disinfection, right? Sterilization, everything is dead, okay? This is usually done with very high levels of heat or pressure, okay? An autoclave is usually used for those surgical utensils. We do not sterilize an ambulance. It doesn't really happen. Versus high-level disinfection, where you're doing a really good job. So this is when they send the ambulance out once a year or whatever and do a disinfection on it. And they spray it all down with the chemicals, maybe some hot water under pressure to kind of kill things a little bit better. What we kind of do on the regular day is intermediate level disinfection, right? Those purple wipes, bleach wipes, whatever other red top, yellow top wipes that you might have. And then you have low level disinfection, which is we're cleaning the floors, maybe, we're just washing our hands, doing a little soap and water on things, right? So you have your different levels of decontamination. We talked already about immune system, right? So if you are exposed, your body launches an immune response, but it takes a little time for it to produce the appropriate white blood cells, etc., to kill the bug. So And I think this is part of the thing that we kind of needed to realize a little bit with COVID, is that yes, it was a very potent, it's a very potent virus, right? It lives for an extended period of time on surfaces, which is your virulence, right? How well does it survive? But we don't know what the dose is, right? So a virus or a bacteria needs to hit a certain level of load in the body before it starts to present with symptoms, right? Because you can have a viral infection, but it's maybe so low that you don't notice. Like anyone who's ever had like a UTI and not noticed that you had a UTI because there was no burning or foul odor or anything like that, the dose of whatever infectious disease might have been too low. Your body had a handle on it, but could have used a little help with some antibiotics. You know what I mean? When that kind of brings us to resistance, right? Does your body have antibodies to launch an attack, right? As a host, are you healthy, right? Do you exercise? Do you eat vegetables? Do you drink water instead of just energy drinks, right? All of those things will help your body launch an appropriate immune response so that you can fight off a potential infectious disease before it becomes very severe or even causes any symptoms at all. And then the mode of entry, right? So if you go and lick like a petri dish full of COVID, you're probably going to get COVID. If you put it in your eye, right, the mucous membrane, you're giving it a direct response. But if you take that petri dish and then wipe it on your arm and you have unbroken skin, you probably won't get it as long as you don't go lick it or something afterwards, right? Or then touch your face. But, the mode of entry is important. So there's a chain of transmission when it comes to infectious diseases. So one, a pathologic agent needs to exist. You need to be in the same environment as the pathogenic agent. A reservoir of that agent needs to then be created inside of the body. Okay, so that might be an abscessed tooth, if it's a good kind of mental spot for it. Then if it's inside of another host, it needs to have a level exit, right? So if you have a reservoir of COVID-19 in your nasal passage and you sneeze, there's your portal of exit. Now your transmission is you, as an uninfected individual, prancing through that cloud of sneeze with no mask on. Then that portal of entry becomes your nasal mucosa. If you are super healthy and feeling good, you might not get sick. If you kind of were a little under the weather, you didn't get a full night's sleep, you haven't eaten a vegetable in 3 months, you'll probably be more susceptible, which allows that pathogenic agent to propagate, okay? And then the chain continues. Pathogenic agent is anything that can cause disease, okay? Viruses are not living things, okay? They're just this little strand of RNA that requires a host to give it a little room, a little home to live in. Bacteria are living things. Some of them are able to live outside of a host. Some of them are not. Depends on what kind of bacteria it is. Some bacteria are aerobic, which means that they require oxygen to thrive, whereas some bacteria are anaerobic, which means that they don't need oxygen to survive. So one of my favorite bacterial infections is necrotizing fasciitis. It is an anaerobic bacteria, and it lives and creates infection in that space between your skin and your muscle, that fascia, that like thick tendinous material that covers your muscles. Okay, doesn't need a bacteria to oxygen to live, grows really well, kind of sneaky. All sorts of wild things happen with it. Bacteria can be classified by a number of different things, including its shape, viability, chemical composition, exactly. Bacteria can be killed, whereas viruses are difficult to eradicate because they have now hijacked your own cells against you and turned them into viruses. They're kind of like zombies, if you want to think of it that way, or vampires, where they bite you and they turn you into one of them, and then that continues to go on and creates the infection. But then it kind of meshes with the DNA of the host cell and changes it inherently. Um, Other things that kind of influence, right, the ability for you to get sick or an ability for a pathogenic agent to take hold of you. How well can it reproduce, right? And no, it doesn't need to bring a girlfriend or boyfriend with it. Um, how is it getting into the host, right? So like if it's a aerobic bacteria and it gets inserted via a puncture wound where there's no oxygen, it's not going to be able to reproduce. Okay, if it's a bacteria that requires a non-acidic environment to reproduce and it ends up in your stomach, it's not going to reproduce. How quickly can it reproduce, right? Because if it's a very slow reproduction, your immune system will usually get rid of it before it can create symptoms and cause an actual infection. But does it create a toxin, right? Botulism. Botulism is caused by a bacteria, but the bacteria creates a toxin which causes that paralytic kind of response. Botox is botulism. It takes that toxin and uses it to paralyze your muscles so that you look happy all the time. Okay? Is the toxin causing tissue damage? Is the bacteria causing tissue damage? How potent is that pathogen, right? Is it very able to be killed easily, or is it not kind of more potent and strong? And then is it able to evade an immune response, right? Does it set up shop in a place where the immune system can't find it? Okay? These are things that, kind of are taken into consideration when you're dealing with a pathogenic agent. Reservoir, we talked about this already, right? There's a number of places where you can pick up a bacteria or virus from, okay? Anything from food, right? If you get food poisoning, to another human, to a mosquito, to fleas and ticks, okay? Any of those things can provide a reservoir for a pathogenic agent. Portal of exit, we talked about this already. Mode of transmission. Again, we talked about this. Direct mode of transmission is physical contact, so like, shaking hands or kissing, versus indirect, where it's either that you have walked through a reservoir of, droplets, or food, or an animal can cause indirect, whatchamacallit. Your mucosal membranes are probably your number one mode of transmission, portal of entry, okay, right? You have a lot of them. Your mouth, your nose, sexual regions, right? So these are a lot of the areas that usually portal of entries are. Broken skin is probably also high on the list of potential portals of entry. This is why, we put Band-Aids on, essentially. Again, we talked about this as well. In terms of cultural behaviors, this is also like your willingness or ability to go to the hospital, right? Or go to a doctor. So if you're not feeling well, or, you don't have access to a doctor on a regular basis, your health might not be as well maintained. Cultural behavior in so much as, like, think about EMS. Like, when's the last time that any of us have gone to the doctor? Because we're good, I work in healthcare, I don't really need to go to the doctor, okay? Cultural isn't necessarily just, like, ethnically cultural. It can also be professionally cultural. Cops, firemen, all of those first responder groups, that culture puts us at risk as well, because that mentality is just kind of silly. Here's some other things that can cause issues. Eating habits, hygiene, sexual behaviors, weather, geographically, what you will be exposed to, water sanitation, right? Think about people who go to Mexico, right? They say, oh, don't drink the water. That's why. Any other immune status, right? Are you have an autoimmune disease where you might be on an immunosuppressant? Are you eating well? Are you sleeping well? Have you been predisposed to things based on your, heredity, etc.? You have 100 trillion bacteria that live on or in your body. So not only do you have your own immune system protecting you, but you also have 1 trillion bacteria that are part of you that are protecting you, which is kind of crazy. So they're the ones who are like, no, no, we've set up a colony here in the armpit. I don't know who you are, but you're not welcome here, and they'll attack other bacteria. So this is why we don't get sick like every other day, because you know that we're coming in contact with all sorts of randomness. Your normal flora actually does a really great job of keeping you healthy. A lot of those flora live inside your GI tract. So anything that you have taken, this is like, food poisoning and stuff like that. If you take it in a little odd looking food, those guys help you out a lot. Your skin is also the first line of defense, and that's usually a good test question that you'll see pop up. Yes, when you're born. Yes, some of those bacteria are acquired when you are vaginally born. It's a very strong possibility. They're actually doing a lot of research on that, actually, which is kind of wild. I'll see if I can find. I'll make a little note for you. I'll see if I can find C-section flora research. They're doing a lot of research on it right now because they're not sure if that's putting those children at a deficit, because you do acquire a lot of these bacteria just kind of wandering out around in the day. So think about children who breastfeed also pick up normal flora from mother's breast, okay, from the skin contact. This is why they also promote skin to skin contact, because baby can pick up a lot of those bacteria. So there's a lot of really cool ways that you can pick up bacteria, but yes, the vaginal tract is the first way that babies pick up some of that normal flora from mom, and it starts to contribute to their own line of defense. I also saw a really interesting research article that talked about how women have, mostly women, I think they researched, but I think men also have this ability to detect bacteria on their partner, and that like odor / pheromone kind of vibe will actually help choose a partner. So like people like, oh, I fell in love with this person and I don't know why. It's because you're bacterially compatible, whereas you have found someone whose bacteria biome matches yours adequately, but is also different enough where it will promote a healthy offspring. #science. Pretty wild stuff. So that's a little tidbit of information for the day. Thank you for coming to my TED Talk. So we talked about the skin. We talked about the GI system, upper respiratory tract, right? And this is why smoking is bad for you, because it debilitates the cilia in your upper respiratory tract via heat. Even if you're vaping, heat is bad for you because it takes those cilia and paralyzes them. So you will actually get more upper respiratory tract infections because it can't kick the bacteria out. GU tract, right? So your urination, the constant flow of urination helps kill bacteria. There was a myth that urine is sterile. Urine is not sterile. Urine does possess a certain level of normal bacteria, just like everything else in your system, because remember, we have a symbiotic relationship with our bacteria. We talked about the internal barriers, right? Your inflammatory response is designed to keep the antigen or the bacteria or the infection kind of separate from the rest of the body, right? It's trying to limit its ability to spread. So this is going to increase blood flow to an area. That's why when you have like a infection, like a it gets really red and swollen and angry, is because this is your body's normal response. It's increasing blood flow to the area to help bring more white blood cells there, to help bring more of those chemical mediators into the area so that it will reduce the infection and basically bring soldiers to the playing field. There's a number of different stages where depending on what the disease is, it depends. Where, first of all, you end up in the latent stage, right? The pathogen's in the body, it's setting up shop, it's deciding where it wants to land and how aggressively it's going to attack you. And then there's the communicability stage, right? So this is one of those issues that we were seeing with COVID is usually the communicability stage is associated with some level of symptoms, right? There's a sneeze, there's a cough, there's something kind of telltale sign, fever, that tells you that you're sick and that you might be infectious. COVID doesn't necessarily have a very well-defined communicability stage, so this is why we're having all of these issues with the masks and all that other jazz. Incubation is that interval between the first exposure and when there's enough bacteria or virus in the body to create an antibody response, or an antibody production and white blood cell response. And then there's the disease stage. Sometimes we have a disease stage, sometimes we don't, right? This is like, again, with COVID, you might be completely asymptomatic, which means that you are sick, but you don't know it. Or you can be super sick, right? You're sick in bed with the chills and the cough and the fever, and you're just not feeling well. Your body pitches a fever in an attempt to make your body less habitable for the bacteria or the virus. So like talking about how if a bacteria doesn't want to be in an acidic environment, it won't survive in your stomach. Bacteria needs to be in a specific temperature, around that 98.6 range, in order to keep itself alive. So if your body's like, this doesn't belong here, it's essentially trying to burn it out with a fever. HIV. This country is going through what they're calling the graying of AIDS, because we have done such a fantastic job of reducing the impact of HIV and AIDS on the population through the use of antiretrovirals. It does not mean necessarily that it is not able to be transmitted. It depends again on the viral load. So if you have a patient who is compliant with all of their medications, they have not had a detectable viral load in years, it's unlikely that you are going to get HIV from exposure with their blood, okay? However, if you have a patient who is full-blown HIV positive and they aren't taking medications and they're very sick, it's a much stronger possibility that you'll end up potentially contracting something from that patient, okay? There's plenty of people who we don't know even have HIV and AIDS. And originally the issue was unprotected sex and drug use, okay? Transplants were an issue as well. Blood transfusions were also potentially an issue, but I think they've done a lot of that screening now that's not as big of a deal, where that those are potential vectors. Here we go. Talked about this. Frenching. I definitely put that in there as a rare possibility of getting HIV disease because it was hilarious to me. Enjoy. Okay. So there's two types of HIV. It's HIV-1 or HIV-2. They attack the T cells and they take over them. And then they reduce the ability of the body to make T cells, right? And remember, if we go back to whatchamacallit, I'm having a moment. If you go back to immunology, right? T cells are super important to the whole immune response. HIV doesn't kill patients. It's the opportunistic infections that do. Okay? There's a lot of other things that come along with HIV, such as early onset dementia, HIV encephalitis, cancer, tuberculosis, just pneumonia. Really, pneumonia is, I think, like probably the number one killer of patients who have HIV. Here's a fun picture, right? So the viral DNA ends up inside the T cell, and it starts to create more and more T cells that are HIV positive, okay? So you're not making appropriate T cells, you're just making HIV zombie cells. Hold on, let me see if I can make this a little bit bigger. Nope, that didn't work. There's an acute infection. Usually there's like a flu-like symptom if a patient has become infected with HIV, and a transient decrease in the T cell count. And then it could sit latent for years without them knowing. If it's a low viral load, it's a low likelihood that the disease will be transmitted, especially if antivirals are on board. And then it can progress to AIDS if the medications the antivirals aren't taken appropriately. The immune system completely falls apart, and an opportunistic disease will take hold, right? So there's so much virus in the body that the antiretrovirals aren't able to control it any longer. So if you kind of see right here, in like the early 90s, late 80s, a lot of people were dying from HIV and AIDS. But if you see even like 2011, there's just reduced numbers of people who are dying. So you may never have a patient with who you interact who actually has HIV or AIDS, because it is becoming less likely, a possibility. A lot of times it's actually in low socioeconomic areas because patients can't afford their antiretrovirals, or countries that don't have a well-established healthcare system. HIV is not a huge risk to EMS. You really do need to have a large amount of viral load to create an infection for yourself, for you to be exposed to. The bigger risk is actually hepatitis B. Okay, hepatitis B is a much higher risk than HIV. Test question. Tracy Allen Lee was the first patient who contracted HIV from a patient and then subsequently died from it. And in shock and surprise, New York City denied her line of duty death benefits. So she actually, it's really sad, they just did an article on her recently that her last 3 years of her life, she actually decided that she was going to forego treatment, because not only could she not afford it because of New York City denying her benefits, but because she actually just wanted to enjoy herself. So she, spent the last years of her life actually trying to, live life to the fullest. Moral of the story, don't work for Fitney. Moving on. If you are exposed, right, there's the post-exposure prophylaxis. You get the magical PEP, depending on what it is. You could have a lot of really fun incidental weight loss. The 6 to 9 month cocktail for TB is quite devastating to the body. The HIV PEP is also quite a hit. HBV, which is the hepatitis B virus, you should just get the vaccine. It's a lot less enthusiastic. Hepatitis is inflammation of the liver. There's a lot of people who end up getting hepatitis, commonly hepatitis A, who it runs the course of similarly to food poisoning, and they never really know it's even hepatitis. Hepatitis A is preventable through a vaccine, as is hepatitis B. Hepatitis C is not. However, they have developed an antiviral treatment for it relatively recently and have had research to back the ability to clear the HCV virus from the body. Hepatitis A is commonly the fecal oral route, so like food that's prepared by someone who didn't wash their hands appropriately. You can end up in a chronic liver disease, chronic carrier state for hepatitis A, but commonly it just passes through the body and after like a really bad bout of food poisoning, and then you move on with your life. Hepatitis B, again, you can have a persistent carrier state, or it could produce a chronic infection. Hepatitis B and hepatitis C are high risk for chronic cirrhosis potential. Liver failure, again, is another one. Walked into a house once and this lady was just full on yellow. And I was like, well, she has a hepatitis of some sort or another. Like, you could tell. Like, she was sitting there and, like, I'm looking at her family. This lady was, like, Big Bird yellow, but, like, if Big Bird was, like, a dark, like, urine-y color. And I'm like, and no one saw this happening in this family? Nobody? Not a single one of y'all looked at this lady, like, 2 weeks ago, were like, damn, you're really yellow. Maybe you should go to the doctor. People, I can't. HIV, right? Flu-like, food poisoning-like symptoms. You very commonly seen in places that have poor hygiene or where food is prepared poorly. Illicit drugs, always a risk factor for almost any infection, any kind. Hepatitis, 100 times more infectious than HIV. It is a much more virulent and potent virus than HIV is. HIV is extremely fragile, where hepatitis B can live in dry blood for 7 to 14 days. Okay, and this is why it's important to clean your ambulances very well. Okay, again, flu-like symptoms. It could present as again, like that. Oh my goodness. Just like yellowing of the skin and mucosal membranes. You could have coagulation issues because it affects the liver, and your liver is responsible for your clotting factors. So if your liver is busy dealing with a hepatitis infection, it's not going to be able to help you create coagulation factors. Hepatitis C, a lot of patients don't even know that they have hepatitis C. Jaundice. That was a word I was looking for that I couldn't think of. Patients could be jaundiced. It might start, non-specific symptoms a few months later. And then a lot of patients can end up with a liver crisis, liver failure, or bad liver cirrhosis and die from it. But as I said, they've developed some drugs that are actually getting rid of hepatitis C, so if patients actually diagnosed with it, they can be treated appropriately. Tuberculosis, we get the TB test, right? You get that PPD every single year. Unfortunately, if you were born out of this country, you have been given the tuberculosis vaccine. So you will always test positive on a PPD test, and you need to get a chest x-ray every 2 years. It's spread through droplets, okay? And it can cause like this nodule inside the lung. It's extremely infectious if you are inside an enclosed space breathing the same droplets and same air as a patient who has TB. It needs to be an extended period of time, okay? And by an extended period of time, they usually mean upwards of an hour or more. Patients who are in enclosed spaces who are at increased risk of tuberculosis are patients like those who are at, a homeless shelter, okay? Traditionally, tuberculosis presents with night sweats, chills, fever, coughing up blood, just chest pain, right, when they're coughing, that kind of like rattly cough. The kind of interesting part of tuberculosis is it can actually wander about and affect organs outside of the lungs. There is cutaneous tuberculosis, which actually is a tuberculosis infection inside the skin, which can cause like weird patches of skin to kind of grow. It can also wander into, the cardiovascular system, the central nervous system, and create all sorts of other issues for a patient who has tuberculosis. Purple wipes do kill tuberculosis. So make sure that you clean everything really, really well. And N95 is, again, I think everyone should be wearing those. And ambulance ventilation is extremely important. Bacterial meningitis is much more deadly than viral meningitis, okay? Again, this is commonly found in close living quarters like college dormitories, okay? And it can be spread very easily. This is why a lot of kids who go away to school are required to get the the bacterial meningitis vaccine before they are allowed to dorm. Um, the number of different bacteria can cause bacterial meningitis. N. meningitidis is one of the most common. Um, Usually, the N. meningitidis is found pretty much almost anywhere inside your body. Can be found anywhere, and usually your epithelial lining prevents it from becoming an issue. But again, if you are not feeling well, if you are comorbid factors, smoking or poor nutrition or poor sleep, all of these things can become risk factors for you developing some of these issues. There is a prep for potential exposure for it. Again, enjoy your unplanned diet. Younger children are very susceptible to S. pneumoniae as a cause of bacterial meningitis, which is due commonly to the fact that it's really what causes an ear infection, and then it tends to spread. Group B strep is also a possibility for some children because it can cause, at birth, they can be exposed to it vaginally. Joni, we were talking about that right before, right? So not necessarily all the flora is good. If they are exposed to group B streptococcus, they have a very high risk of meningitis. Commonly, they will test mom for group B streptococcus prior to delivering, and if she is positive for group B streptococcus, which is fun to say, they will give the baby prophylactic antibiotics right after birth in order to prevent them from getting meningitis. This is also part of the reason, like if you have a baby in a hospital, they clean their eyes out because they're putting like antibiotics into their eyes to make sure that they don't get any of these really random things. The hallmark sign of meningitis is nuchal rigidity. Nuchal, N-U-C-H-A-L, okay? Test question. These are two tests that you could potentially do if you really wanted to. They're very sensitive to meningitis. About 95% of patients with meningitis will test positive for one of these or the other, or both. Brzezinski's sign is when you lay a patient supine and with their legs, their knees not flexed, and you lift their head, their knee will involuntarily flex because their swelling in the spinal cord is preventing them from bringing their chin to their chest, which is the nuchal rigidity, okay? And that inflammation of the spinal cord just tightens everything up and the knees pop up. Again, viral meningitis. The reason that viral meningitis is usually less deadly than bacterial meningitis is because it is self-limiting. The virus that kind of pops up in there is not as potent as the bacteria is. A number of various viruses can cause meningitis. It's just about how it's able to get into the central nervous system and into the meninges. Most of the time, it's kind of associated with another viral infection. So you might have a patient who has fever, cough, secondary to flu, who also has that nuchal rigidity and is having other, head or, AMS or neural symptoms. There are a various number of meningitis immunizations. We talked about that already, so we'll move on. Bacterial endocarditis. It is an infection of the endocardium, which is the actual inside lining of the heart and or the heart valves. Most of the time, this is caused by either A, dental procedures, or B, IV drug use. So what happens is this bacteria wanders over into the heart, sets up shop, and causes vegetation on the heart valves. This is one of the number one reasons that it's probably the number two reason that young patients are getting a heart valve replacement. Okay, it's not a common thing. There might be somebody who has severe congenital heart defects who needs a heart valve replacement, but for the most part, it's secondary to endocarditis because the bacteria destroys the heart valve and creates all sorts of issues. Look at that delicious vegetation. Most of the time, men over 60 are the ones who end up with bacterial endocarditis if they're not, chronic IV drug users. It's usually that dental, right? This is why they give patients, especially older patients, prophylactic antibiotics prior to dental work. Random things that will tell you that your patient has bacterial endocarditis. Osler nodes, which is like a dark lump on the thumb. Janeway lesions, which are like weird marks on the hands. Or splinter hemorrhages under the nails. You can kind of see the dark bruising, like splinter-shaped bruising underneath the fingernail beds, is a really good sign for bacterial endocarditis, which you may or may not be able to detect. Your EKG probably will have some sort of funkiness to it, but there's a lot of different symptoms that it can present, and it might present as kind of one of those vague, yep, you're sick, don't know why, kind of issues. Pneumonia can be caused by bacteria, virus, fungus, or anything inside the lung that is not supposed to be there, which is really anything other than air. If it is bacterial or viral, it can be spread through direct and indirect means. It's that consolidation of bacteria or virus, right, that sort of starts to bring all the white blood cells and everything else into the area. It can cause significant respiratory distress, obviously. I think we've all had a patient who's had pneumonia before. Some patients never ever present with like a fever or anything. They might just present with like a fever or just like some chills. They might have just some shortness of breath. They might not be, like, they might be a little altered, might be a little confused. There's really no quote-unquote traditional way that pneumonia presents in every single person, okay? How many people have had walking pneumonia before, right? And you're like, I feel a little short of breath, I don't feel good. And then they're like, oh yeah, because you have pneumonia. And you're like, what? That's wild. Tetanus, we talked about this. Brought to you by Clostridium tetani spores. It's usually found in soil and manure. This is why if you are ever involved in a car accident or touch a rusty nail or something else that's been outside, they recommend that you do get a tetanus booster. And you also do require a tetanus booster about every 10 years in order to keep yourself protected from it, because it's pretty popular. It happens to be all over the environment that you're like living in. Anyway, tetanus can kill you because of the severe spasms of the respiratory muscles. There it is. Tetany is a contraction of all of the muscles that causes a lot of, not only is it painful, but it can cause very severe contractions of the muscles in the trunk and in the rest of the body, actually. It creates what they call a grotesque smile. Tetanus was like one of the smiling diseases that would kill people back in the day before they knew what it was. Rabies. Rabies is fun. Possums cannot carry rabies. Here's your the more you know bit of knowledge for the day. Possums are immune to rabies, so you don't have to worry about those guys. Everybody else, though, can carry rabies. There is a really good episode of House where a patient has rabies. Google it. You can watch it. It's a viral infection that is spread through saliva that is extremely potent. Any sort of animal that's acting bizarre outside their normal habitat, right? Like how many times you see a raccoon just kind of chilling during the daylight. They're kind of a nighttime vibe. Humans are super susceptible. You do require, if you do have an animal bite of an unknown animal, they do recommend that the patient, you get the rabies shots. And again, it really depends on how much saliva was really transmitted into the wound. It can have an incubation period, or it can start creating issues right away. Initially, it presents with a low-grade fever, headache, maybe some loss of appetite. As it starts to get worse, seizures can set in, and intense thirst accompanied by hydrophobia. So, like, you're thirsty, but you're afraid of water, which is caused by the virus attacking the brain. If you do receive the rabies shots within 2 days of a bite, you will almost always prevent development, but once the symptoms start to set in, you will probably die. So, moral of the story, don't get bit by a rabid animal. In case you were wondering, here in New York, raccoons, number one, followed by bats, carriers. If you'd like to go get bit by something a little more exotic, I recommend the mongoose. Those guys apparently hang out. I do enjoy the hantavirus. That's one of like the more interesting ones that you don't see very commonly. It's a virus transmitted through the inhalation of rodent urine or feces. So like imagine you're cleaning out your garage and you find a mouse nest, and as you're throwing out the mouse nest, it's all of those particles start to kind of go into the air and you inhale them. There is a strong possibility that you could get hantavirus from inhaling those materials. And it again depends on like the type of mouse that you also, or rat that you, their waste products that you inhale. So if it's an Asian mouse, it's usually a hemorrhagic fever. If it's a American mouse, syndrome, like severe respiratory disease, distress, and shock. So like that, like cleaning up mice droppings can be very dangerous if you don't do so properly. So, just it's a good strong possibility that, putting on an N95 is a good idea. Most of the time it's like fever and malaise and respiratory distress. So again, it could be corona. It could be hantavirus. Will we ever know? Probably not. If it gets really, really bad, you can end up with kidney failure, secondary to all the other symptoms, and hypotension. Things you didn't know that you needed to know. Mice. So deer mice are usually the traditional carriers of hantavirus, whereas the house mouse, which is just the cutest, deer mice have that white underbelly, whereas field mice do not. Rats, bigger. I don't know. You might see some of those in the subway. Clearly they don't carry hantavirus. Mosquito-borne illnesses. Right, there's a lot of different vectors that carry illnesses. It's amazing humans have made it as far as they have. Personal protection, wear your mosquito repellent and/or carry a bug zapper. There's a bunch of different vaccines that you cannot get, or there's a bunch of different diseases you cannot get vaccines for, which are carried by mosquitoes. Chikungunya, there you go. Usually if it's a traveler returning from an affected area, a lot of these mosquito-borne illnesses do sort of persist in, in very tropical locations, okay? But as you've seen, like they can start to kind of travel with airliners, okay? So one of the first non-travel related Zika confirmed Zika cases in the United States was secondary to someone receiving a mosquito bite from a mosquito that actually traveled from a Zika area. Like, who does that? This little mosquito was like, guess what, guys? I'm going on vacation. I'm going to New York. And, like, jumped on a plane and took a ride and it caused Zika up here. Malaria is a parasite as opposed to a virus, where the other ones are viral. So hydroxychloroquine is approved to treat malaria, in case you were wondering, since that's kind of pertinent these days. Malaria can cause all sorts of different issues, like AMS, respiratory diseases, or respiratory failures. But if you look at all of the symptoms, for the most part, it's a fever, headache, body aches, right? So it kind of does mimic a flu. But now this is when you're kind of looking at alternative methods of like recent travel. For the most part, recent travel is probably the number one way that you're going to find out. If anyone has worked in transport, I'm sure you're very familiar with the antibiotic-resistant infections. There's about 18 different drug-resistant bacteria right now, and I do believe that that list is growing rather rapidly, because we like to give antibiotics for just whatever, right? And then people don't actually finish their course of antibiotics, so you're just creating these super bugs. Urgent threats, C. diff. Yeah, no one likes that one. CRE is another one, if you've seen that. VRE is another one. There's a lot of different ones. C. diff causes literally life-threatening diarrhea because you become so dehydrated from the sheer amount of diarrhea that you could die. You will know the smell of C. diff. It is a very potent, it is like a very distinct smell. It's usually associated with an extended antibiotic therapy. And the spores that the C. diff bacteria create need to be destroyed through hand washing, okay? They do not get destroyed by hand sanitizer. Moving on, CRE is other difficult to treat bacterial infections. Most of the time, patients who are dealing with a CRE resistant bacteria like Klebsiella or E. coli will die from a severe septic reaction. Again, this is caused by long-term antibiotics. And, in case you weren't having a bad enough day, and gonorrhea is a drug-resistant gonorrhea, enjoy your persistent clap. What was it, mumps? Measles was making a comeback. I think it was mumps. Thanks, anti-vaxxers, for creating childhood problems where we didn't have to. Rubella is German measles. Usually it's one of the highly communicable viral diseases. Most childhood diseases are super communicable because if you think about it, one, it's happening in childhood, and two, kids like to touch each other. So it's usually really easy for that to spread. Usually it's a facial macular rash, and it usually lasts for about 3 days. If a mom has measles while she is pregnant, she can end up passing on severe congenital defects to her child, including blindness and deafness. Regular old measles, which is rubeola, is less German, therefore less angry, is again a viral disease and very communicable. Fever, conjunctivitis, a blotchy red rash, can last. Usually the difference is that for the most part, most rashes don't show up on like the feet. Measles shows up on the feet, and I believe mumps is the only one that shows up on the hands. Like the palms of the hands. So measles was the one that was having a really delightful outbreak. Thank you, courtesy of the ridiculous anti-vaxxing thing. New York, we got to do things big or then we go home. So we had a lot of issues with the measles outbreak. Mumps is usually brought to you by a severe swelling of the salivary glands. Okay. It has the potential to create airway compromise. So this is a child who you might want to have, very careful eye on while you're taking care of them. Again, we have vaccines for all of these things, so it's kind of unlikely that you're going to see these unless you're working in the city, especially in parts of Brooklyn, where there are certain communities that think that it's super hip or religiously chill to not vaccinate their children. Mumps can also affect other glandular and nervous tissues. The testes, for example, can be affected. There is a chickenpox vaccine here these days. Chickenpox is a respiratory droplet, or if you come in contact with the discharge from one of the pox, the broken pox when a child scratches. Sudden onset of a low-grade fever, some flu-like symptoms, mild malaise, and then you get 3 to 4 days of these vesicular pox. Usually it starts on the trunk first. The difference between chickenpox and smallpox is that chickenpox has vesicular eruptions in different stages. So you might have one area that is almost healed while you have a new eruption somewhere else. Whereas smallpox, it's all one age. Not that we really see smallpox all that much, but hey, it's 2020, who knows? So this is the progression of a chickenpox pox, in case you were wondering, if anyone has never had it. The problem with chickenpox is that even though you may have gotten rid of it as a child, it will lay asymptomatically latent inside the body on a dorsal root ganglia, basically a nerve root. And then when you are older, if you are super stressed or if you have an episode of immune suppression, it can pop back up as shingles. Shingles are super contagious also, okay? But only if you come in contact with the vesicles. So what happens is the shingles kind of pop up along a dermatome. So depending on which nerve root the virus has taken up shop in is going to be where it spreads. And usually it's unilateral. It's very painful for the patient, and it can cause, depending on where it is, if it comes up, it can pop up across eyes. And it can happen in mouths, which can cause issues when it comes to eating. It can cause blindness if it pops up in the eyes and stuff like that. Issues. Pertussis or whooping cough, okay, commonly causes little respiratory issues in younger children. It has that very distinct seal bark cough. The problem is if they're very young, the child is very young, it can cause severe respiratory distress and or failure because it's just not enough air for them to take in. The coughing fits can last for a very long time where the baby can actually become hypoxic. And again, it's not a short bout of being sick. It can be a very long, of illness. Other things that are super common, RSV virus is the number one cause of little kids getting sick, and especially in the winter months. This is the virus when they go back to school. This is what they all get. It's RSV. Croup, right? I think we're relatively familiar with croup. Again, upper airways, they have that seal bark. They'll have a low-grade fever. Epiglottitis is a sore throat, very, very high fever, and airway, some swelling and hoarseness in the airway. Flu, again, we talked about flu already, rapid. SARS, yet again, we're living SARS right now with just the coronavirus. This slide aged well. Droplet precautions are pretty much any respiratory disease. Droplet precautions are high. You need to be taken. Mononucleosis. So, fun fact, about 90% of the world has had mono at one point or another and never known it. 80% of people actually get it as a small child and have a short flu-like symptom illness that just goes away, right? So they're kind of sleepy, a little fever, right? And then maybe a sore throat, and then it goes away. Mono is caused by Epstein-Barr virus, sometimes a cytomegalovirus, but most of the time Epstein-Barr. There is a version of the Epstein-Barr virus, it's the Japanese strain, that actually creates recurrent strains of mono, because having it once wasn't fun enough. And a lot of patients will end up with having, they'll never know, but they'll have, antibodies later in life. And it's spread through the oropharyngeal and saliva route, which is why it's called the kissing disease. STDs, we're going to go through these really quickly because, one, you should have done this in health class in the 8th grade, and two, I'm not testing you on sexually transmitted diseases. Syphilis is probably the most important because it can cause all sorts of really weird mental issues if it gets to stage 3 and is never treated. Syphilis is really easily treated with antibiotics. However, if it is untreated, it can cause dementia and all sorts of other problems. Again, really good episode of House that covers that. There's usually lesions that are caused by syphilis in the mucous membranes. Moving on. Gonorrhea. Usually it kind of has the same presentation as initially as like a UTI. Many patients will remain asymptomatic. Again, treatable with antibiotics. But if it is allowed to spread, it can cause all sorts of other issues, including sterility. I'm going to send you all this link later so you can enjoy this by yourselves in the privacy of your own home. Chlamydia, again, super common. Ironically, one of the most common STDs transmitted in nursing homes. Because when you get old and you're in a nursing home and assisted living and you have nothing else to do, you have wild, unprotected sex at 80 years old. There you go. Break it down. Also cause all sorts of other random infections. You can transmit it to children at birth. Again, discharge, sterility issues. Herpes. So whereas chickenpox is a herpes zoster virus, herpes simplex is usually what causes either A, cold sores, or B, like genital herpes. Simplex 1 is the cold sore one. Simplex 2 is the genital one. It's transmitted through skin-to-skin contact, but patients might be asymptomatic. There can be episodic outbreaks, which is usually when the patient is more infectious and communicable. Lice and scabies, super exciting. Lice lives in the hair. Brought to you by usually elementary school children. They, bleh, I can't. They're gross. Egg nymph adult, itchy scalp, cold, I don't know, gross. Pubic lice, they look like little tiny crabs, which is ironically how they got their name as crabs, in case anyone missed that part of health class in 8th grade. Most of the time, the eggs are the most evident part. Amusingly, men with like a lot of body hair were found to be more attractive back in like the Victorian ages and stuff because women were able to determine if they had lice because the body hair would pretty much exhibit the eggs and like the little lice crawling around. So like women were more attracted to men with body hair because they could essentially check them for cleanliness. Thank you for coming to my random facts TED Talk. Head lice, pubic lice. Nah, long and skinny, more like an angry crab. Scabies are by far one of the things that give me the worst heebie-jeebies. They are a parasite that lives on a host, obviously, and it looks a lot like a lice infection, except the scabies burrow into the skin. So you'll get these, if you see in this top picture right here, this like very distinct looking burrow underneath the skin. They're very, very itchy. They lay eggs, not F's. Effing eggs, perhaps. And they'll live there, and the eggs will like sit under the skin for like up to a month before they hatch and make more scabies. So basically, the treatment for scabies is they give you this anti-scabies cream that you have to rub all over your body, and then a month later, you do it again. Scabies primarily show up as inside the webbing of the fingers, and very rarely show up above a collarbone. Like they don't go up into the daylight. Apparently, they like to stay in like underneath everything. So you're welcome for that horror movie moment. Questions? Who's itchy now? What we got in the chat? Yeah, contact tracing. There's a lot of things with infection control that could be done loads better. But anywho. Questions, thoughts, concerns, recipes. How's Medicat? Shocker. right, cool. So if y'all don't have anything, let me know. I'm gonna send you that YouTube video. Just it's silly and short. It was done by like a comedy group. Um, it it might brighten your day. I will get to the endocrinology lecture re-recording. I'm going to recommend that you actually watch it. If you don't, I can't make you. But if you were not in the lecture last Monday, then I highly recommend you do watch it. And good news, you won't have to watch me twice. Don't forget to do your quiz. Please do your freaking homework. And other than that, have a lovely day, everybody.